You're listening to Risk and Resolve, where leadership, business, and risk management collide. We bring you real conversations, sharp insights, and strategies for success. And now for your hosts, Conner and Todd Hufford.
Welcome back to another episode of Risk and Resolve. I'm Conner alongside Todd Hufford. And today our guest is Dr. Burrer, my family physician, my personal physician. And Dr. Burrer is a board certified family physician and founder of Valor Direct Primary Care in Carmel, Indiana. Dr. Burrer, how are you today?
I am doing well today. It's so nice to be able to sort of do something a little bit different than my daily thing. So to be able to talk to some people, do a podcast is sort of thrilling, and maybe I'm just a little nervous about it. I don't get to do these things.
We'll have a lot of fun. So usually, you get time interviewing your patients, and now that the tide has turned and the questions will be coming your way. And what's kind of interesting is most people would have no ability to have this kind of a conversation with their doctor. It just would never exist. And you know what? We'll get into that here in a little bit. But before we dive into all the things special about DPC and you, let's rewind the clock a little bit and just give the audience a little bit of your background, just who you are as a person and that sort of thing.
Sure. Let's see, where would I start? I guess I'll start in the beginning. So I grew up in Boston, and hopefully you won't be able to tell that from my accent, but I think I don't have much of an accent, but a few words sneak out. So grew up in Boston, and when I was a little kid, maybe 6 years old, I wanted to be a doctor. It was kind of interesting in that I remember my pediatrician as some mean old man. In reality, he was probably like super lovely, kind, grandfatherly figure. He probably wasn't even that old, but I was just scared of him. And I don't know why that would make me want to be a doctor, other than that otoscope, that ear flashlight thing was so cool that I think world peace. That's I wanted to achieve that, but I really liked the flashlight, and I thought I could be better than this guy. And I think in New England, outside of Boston, if you tell your parents you want to be a doctor, they're okay with it. So basically, we just ran with that for a while. I thought I wanted to be a vet, and then I found out that I was too caring with animals, and I wasn't. No animal deserves its suffering, but us humans maybe do. But anyway, I always said I wanted to be a doctor and gravitated towards biology, and And so I grew up in Massachusetts, and eventually went to college in Massachusetts, and I wanted to be pre-med all the way. And then interesting thing came along, and that someone suggested that there's a lot of people who are pre-med who look just like me, coming from New England schools, and maybe I wanted to set myself apart a little bit. And they asked me what other things that I was interested in, and I became a biology religion double major, and I was the first at the school to ever do those two things. And the kicker was I was a religion major as an atheist, so I was the darling of the department, because now they had someone they could fight against at everything. They had the atheist, the foil, if you will. So but after I graduated from Tufts, I went on to medical school in Chicago, and met my wife there. She was, when I was a fourth year student, she was a nursing student. So we sort of met at the hospital, and it was love at first sight. So that was amazing. And in medical school, I liked every single thing. So the people that like every rotation, they like surgery, they like dermatology, they like delivering babies, but those people go into family practice because that's it is actually a specialty, but it's the most general of the specialties. And that kind of fit, because when I was a little kid, when I was 6, and said I wanted to be a doctor, the only kind of doctor I really thought about was like a small town doctor. That's the only kind of doctor I kind of knew. And maybe that was from TV shows or just, 1950s kind of feeling. So but yeah. And then after medical school, I moved back to Boston, to Worcester, Massachusetts, and did my residency. And it was in family practice. And it was kind of fun because half the time I was in a hospital, and then the other half the time I would drive 35 miles out to this rural cow town, Barre, Massachusetts. And there was a very well-established clinic out there, but it was really far away. And we got to take care of, like, I don't know if you can call Massachusetts really rural, but it was as rural as you can get. So we got to take care of the farmers and people who never wanted to go to the city. And it was a great time. So I got to kind of train with country doctors doing country doctor things. And yeah, it was a great experience. So shout out to Barry and all the things that my residency friends taught me. I think of them often, almost every day, probably, to be honest with you.
Yeah. You are one of the small percentage of folks, and that's according to the statistics of Ben Conner, that actually became what you dreamed about doing when you were a kid.
Yeah. Yeah, my parents never dissuaded me. I will say that I didn't really know any doctors growing up. I didn't have like a cousin or an uncle or anything like that. So there was no one to tell me sort of the negative. So I kind of had this overwhelmingly, kind of positive, like, doctors are great and everything's wonderful. And why isn't everyone a doctor? I didn't know of the sort of seedy underbelly of, burnout and other things that doctors experience. So I just had this, Norman Rockwell, version of medicine. And and to be honest with you, that kind of shaped me, I think, just sort of seeing the ideal of it. And and I've worked in many different situations. So now I'm in Carmel, like you said, and I'm sort of doing, it's not really a small town here in Carmel, but it's our practice sort of feels like that. But I've had an opportunity to work, for a big institution where I was I was the flea on the camel's backside in terms of low level employee. I've owned a private practice with my best friend that was high end and fancy, and we got to wear white lab coats and look very doctorish. And I've worked in urgent care places. So I've over the years I've moved a lot and worked in different situations. And oddly, that all brought me back to wanting to be kind of a country doctor, although I'm in a suburban setting, but that style of practice. So
yeah. What about the state of medicine, and in your journey kind of steered you toward the direction of the DPC model, which is DPC stands for Direct Primary Care. What steered you in the direction of what you're doing today, just from your experience?
Sure. It seems that the constant battle between, satisfaction and dissatisfaction sort of leans, kind of makes your path. So it was very interesting. So I'm for direct primary care, I'm probably one of the older providers who just started in this. There's plenty of people who've been doing it and they're my age, but to start, I just started 2 years ago, sort of at, sort of the last third of my career, maybe. So prior to this, I've been around long enough to see how insurances have absolutely changed healthcare in so many different ways. So when I first was a doctor, my mentors, remembered the golden age of medicine where if the doctor ordered the test got done. And if the doctor ordered the prescription got filled. There was no prior authorizations, anything you wanted, was there. And I think the doctors held this sort of kind of high place in society. And it was very interesting because soon after that, the insurance companies who were probably footing the bill for every test that the doctor wanted. Matter of fact, there used to be kickbacks. If you ordered an MRI, you got something for that. So it maybe encouraged people to order tests. And then, interesting enough, the insurance companies decided, hey, let's make the doctors pay for the tests. So there was this style of care that was called capitation. I don't know if you remember the days of capitation, but what that was is the doctors were paid this money up front by the insurance companies to manage their panel. So it might have been you would get 50 cents per member per month, and you would have this pool of money. And then when that patient needed the MRI, it would come out of the doctor's kind of pool of money. And if you were, good at managing those patients at the end of the year, you got some money. And if you were not good at managing those patients, you quote, ordered too many tests, you would have less money. So it was this weird incentive. 1 year you're incentivized to order tests and do all the things. And then the next year it's financially a little bit dangerous if you order too many things. And that went on for a while, and some doctors got very good at that. And I have to say that my practice, we got very good at capitation and did very well. And then they flipped it one more time. And now the patient bears the burden, right? With a copay and with a high deductible, and have you hit your out-of-pocket max. So once upon a time, the doctor ordered the test and got a kickback. Then the doctor ordered the test and they actually kind of lost money if they did that. And now the doctor says, I think we should do the test because the lawyers think it's a good idea. And the patient says, I can't afford it. I haven't hit my deductible. It's interesting how the buck has been passed. And probably because of that, I have, soured a little bit on how medicine has behaved themselves and how the doctors kind of rolled over and let all these things happen. Once upon a time, they held a kind of an honored place in society. And now I think a lot of us are just owned by somebody and told what to do and have very little say in how care gets delivered. So me going into direct primary care, I think is a culmination of seeing all these different experiences and seeing medical people, but mostly my patients, just get screwed different ways, and kind of throwing my hands up and saying, I've had enough. I'm not doing it that way anymore. I'm going to try something unique where it's just for the patient's best interest, and try and ignore all the noise that's out there. And there's so many guidelines and things like that are designed really not really with the patient's best interest, but with trying to take care of the entire herd, not just the one patient, but what's good for society and things like that. So it's nice to be able to go back and say, I only care about you, Ben, you, Todd, and what's good for you, what you really need, what we need to work on, and not like what your insurance company will tell us we can do or something like that.
Can you describe the model of direct primary care and how that's different, or what sets that apart from the traditional doctor's office?
I would love to. Yeah. So direct primary care is sort of a new thing in maybe the last 15 to 20 years, but it's really the old style of medicine, the way it used to be before insurance companies. Once upon a time, there was a doctor who lived on Main Street who cared for people in the town, and sure, if your kid was sick, he'd do house calls, or maybe you'd pay him with chickens and apple pies or whatever it was. But it was, you paid the doctor had your back, you worked together. That was it. It was just two people in that relationship. And so direct primary care at this point, we just don't take insurance. They don't pay the doctor's fees. It's just a monthly subscription. And which we should talk more about that, but that radically changes the behavior of or the type of care people receive. I think most of us have been sort of boiled like frogs slowly, and we just accept that, I do an annual physical, I do a 3-month follow-up, and all these kind of things that if you change the model of pay per visit, pay fee for service, versus sort of being in a membership model, it just completely changes how you handle interactions with your patients, and much to the benefit. So direct primary care is a monthly membership, and just like a cell phone or a gym membership, some people use it a lot, some people don't use it very much. So it's a monthly fee, and what the doctors do for that monthly fee is think about you all month, manage all your needs all month. If you're sick and need 4 visits, it's the same price. If you're traveling and you have a problem, they love to take care of you at a distance through telemedicine and phone calls. They're happy to handle text messages, emails. And traditional commercial medicine doesn't get paid for those interactions. They only get paid for their face-to-face time. You're literally buying the doctor's time. So when you're not in front of the doctor, they're not necessarily thinking about you. Whereas if you're on a membership model, you're going to manage that patient all month. So the other things that maybe make us a little bit different, most direct primary care doctors don't have any like contract. So sometimes our concierge medicine friends who do similar kind of things, they might have a long-term contract, whereas the direct primary care people typically have significantly lower monthly fees, and they tend to go month to month. And again, we don't bill insurance. So our patients pay us directly. It's very clear who we work for. However, I deal with insurance companies all day long on my patient's behalf. So if we wanted to put Todd on a brand new GLP-1 medicine and his insurance required a prior authorization, I might prescribe that, and I would fight them tooth and nail through prior authorizations, documentation, phone calls, whatever, to get him that medicine. It's just ironic that they don't pay me, the insurance companies. So, but when you, and I should say, sorry, I'm babbling. This style of care lets you see much fewer patients and still make a living. So a traditional doctor who works for a hospital system in a clinic might have a panel of patients that's 2,500 patients, maybe 3,000 patients. And so they, and again, how many times a year do they see you? Once for a physical, a couple follow-ups, maybe a sick visit.
Maybe none.
Maybe none. And quite honestly, in today's model, if you're sick, they probably won't see you. They'll tell you to go to urgent care. So a direct primary care doctor, someone like me, there's people who have full practices of maybe 500 or 600 patients. And then there's people like me who have what we would call a micro practice. So we have maybe 200 to 300 patients. And so when you have so many less people, you actually get to know them quite well, and there's a certain joy to seeing the person's name on your caller ID and picking up the phone and saying, "Hi, Ben, how are things going?" And like, your patient, you don't have to say, "What's your date of birth?" I'm sorry, what's your telephone number? Like you just know who they are. So so direct primary care is just a throwback to how it used to be in the good old days, still trying to navigate this complex world of health insurance. And what I think is surprising is, you would think this would be great for people without insurance. And I would say if someone doesn't have health insurance, you should grab a direct primary care doctor, because what they can just save you, 1 urgent care visit, 2 urgent care visits in a year, maybe some lab work, they've already paid for the entire membership just on those savings. But most of our patients do have health insurance, and some of them would claim they have great health insurance, but can they be seen? So if someone calls you, will you be seen? So I can just give you an example today. I had 2 patients today who I saw who called me or texted me this morning, right as I opened. One of them had a swollen eye. They came right in. Another one had a bladder infection. We saw them at lunchtime. But the idea is, like you have a small enough panel that, you should be able to see your patients when they're sick. And then, I probably had 3 other patients today that were scheduled routine kind of follow-up stuff. So direct primary care lets you take care of fewer patients in much greater detail and depth. And I think one of the big differences is you think about your panel all the time. You see something on, a crazy podcast, and you're like, that's so interesting. My patient Bob could really benefit from that. And you might call Bob up and say, Bob, I want to go a different direction. You would never, ever do that in the standard model.
No. You mentioned the panel. You call it a panel. It's really your flock. In a lot of ways, you're a shepherd You mentioned earlier going through college as an atheist. How has that transitioned over time to now being a shepherd?
What a better place it is now, wandering in the wilderness. So, I'll tell you a little bit of my religious journey, if you will, because, again, we don't want to maybe go too hard into testimony, but I can't really shut up about it, to be honest with you. It's so vital, I think. So when I was a little kid, and my wife might tell this story differently, which means she probably tells it correctly. But when I was a little kid, my family was, good Americans. So we'd go to church, on Sundays and things like that, but we weren't overly religious, and there wasn't like a Bible on the kitchen table or anything like that. And when I was a little kid, there was a fire and brimstone sort of preaching from probably a really nice old grandfather, but I thought he was scary, just like my pediatrician. And he basically said, you're going to hell if you don't accept Jesus. And I think, that night I was terrified, 6 years old, got on my hands and knees and prayed to God. And, that was the age of Sunday school. So, there was Noah's Ark, and there was talking burning bushes, and there was, Samson doing his, it was all, there were these great stories. So I think as a little kid, I anticipated Jesus coming and sitting on my bedside and, coming to me directly. So, after proclaiming Jesus as a little kid, probably a couple of weeks later, I decided that it was all a lie, and it was just parents trying to keep kids in line with behavior and society trying, whatever it was. I became very sour, and as a little kid, I was an atheist, and I ended up being a relatively well-read atheist, and then finally going to college and like making it a double major. And then graduating from college. And of course, I had biology teaching me evolution. And then I had these, Christian cliches and, creationism and, come on, how could that really be? And went through medical school as an atheist. I married my lovely Christian wife as an atheist. And it was about when I was in my 30s. And I would take my wife to church. I wouldn't go in, but I would drive her there because she's lovely. I'd go to Bible study with her. Her friends were lovely. But it wasn't until I became a dad, and I was, kind of looking at my little kid kicking and screaming every time I tried to change his diaper, that I like softened and thought, I'd do anything for this kid, but I would not sacrifice him for the sake of the world. That I wouldn't do. And I said, I'd sacrifice myself, right? Any good moral human, if, my life for everyone, like, come on, you would do that. You have to do that. And then it kind of dawned on me that, quite honestly, I wouldn't be qualified even if I was willing, to take on that. So I softened to the gospel, and it was very strange because one day I walked into a shower, an atheist, and I walked out of the shower like 15 minutes later, devastated because he was real. So in this shower moment, I had all these little montages of all the places where Christ was with me, and I just didn't know it, or I ignored him. And it was so weird because I went back and saw myself as a 6-year-old praying to him. It like came to me, and I realized I'd been saved since I was 6. I was just a screaming, angry person, and apparently God's universe didn't go according to my will, but to his will. And it took me until I was in my 30s to have my prayer answered. I got my burning bush, I got all of that. It just flooded over me. So it was very interesting to go on the apology tour. Once you're a Christian and you're like, everyone knows you as an atheist, and you've been to Bible study and told people like, they're weak-minded and, all that, anyway, it was quite a time to roll that back and have plenty of catching up to do. So
that's some powerful shampoo you used that day.
Yeah, that was good. It was, I think it was the Irish one that smells good. No, so part of what I do now is, I think because of that. So, my wife and I collectively decided to sort of leave corporate medicine, and, things were fine. I always had a job. Anywhere I went, I could always get a job, and then sort of do this, kind of practice. And we really, a big part of this is we just want to stand apart in our community and just have people wonder why we care so much. And it's interesting because, I'm a flawed human, but you can love with Christ's love and really care for people, so that's kind of why we do this. The name of my practice is Valor Direct Primary Care, and it's not Valor. Boy, someone said that once. So it's Christ's Valor, and we have a big shield and a cross, and we love taking care of people no matter who they are. And so there's a different responsibility that I feel now, maybe like a shepherd with a flock, like you said, because I care about all these people. Whereas in my other practice, I was sort of paid to care for them, and I wanted to give them the best care possible, but it wasn't a like with your heart. It was your livelihood and your calling, your expertise. But now, like I feel much more intimate that I care on a different level, and it's so much more satisfying. Like I really don't know why more doctors. I mean, there's a lot of doctors jumping into this, but what a different level of satisfaction to really care for someone. And like maybe they just have a sinus infection, but to be able to call them a few days later and just say, "Hey, are you doing better?" Like my doctor doesn't do that. Right. I have a commercial corporate doctor, and like unless I reach out, I'll never hear from them or anything like that. So yeah, there's just a little bit more responsibility, but it makes your job so much more satisfying, and it's much more beautiful to do this.
Are the economics, it sounds like there's 1/10 the patients. Certainly there's less overhead. You don't have to hire a bunch of people to do all the billing because that doesn't happen back and forth as much. But do you end up with clients that are paying 5 to 10 times more, but they're getting a whole lot more access? Is that how the math roughly works?
Yes. So, so what's interesting is the overhead is fixed, right? The price of the software, the electricity, the water, the rent, so once you hit a certain number of patients, you break even. And then after that, you decide really how much profit you'd like for the amount of work it takes. And I think what happens is, when you read about this kind of practice or talk to somebody, they always mention this number. If you have 500 patients, this will be what your income is. And, that's pretty good. When I look at that, that's a little bit better than I was earning as a family practice doctor. And then when you're in practice, and now I have about 225 patients, maybe, kind of looking at 250. I work 10 hours a day, work the weekends. I'm on call 24/7. I don't know how anyone can have 500 patients, to be honest with you, at least caring for them like I do.
Right.
So I think and I think we're a little bit different in the direct primary care space. I think we're very happy being a small practice. I don't make the money that I used to make by any means.
You don't have the headaches either.
I don't have the headaches. And quite honestly, I have a little bit of time to think and learn new things. It really wasn't until I started this 2 years ago, that I actually sat down and started reading some medical literature. Yeah. Because I had an interest in it. You always have these continuation of medical credits that you have to do to stay certified. Yeah, so I'd always sort of do those things or go to a conference, but all of a sudden I'm like, I have a little free time to read about insulin resistance and metabolic health. And it's because, a few of my patients really need that. And so it's become personally satisfying. So, but I do think a lot of, people who do that 500 patient panel is exciting. To do that, you really have to hire probably a front desk person and maybe a medical assistant, which again,
or something maybe
adds to the overhead. And it's not really that hard to figure out how much the doctors are making, because you can, everyone's prices are online. So this is a beautiful thing about direct primary care. Everything is super transparent. And every region has sort of a what the market would bear. So if you were in New York City, the prices would be much higher than if you're in Kansas. And every direct primary care person I know has their price smack dab on their website. And and some people offer other services that they might charge for. But
I was looking at just through your LinkedIn. You literally have practiced medicine in every time zone in the United States. Congratulations.
yes, yes, I think we've been east to west, and now we're moving back.
Right. It
Bounce
literally
around.
looked like that. Is
Yeah.
there any observations you've made about, and obviously time zone's a big category. So you were in Colorado, you were in Chicago, you were in Boston, you're in Indy, and you were out in Oregon, I believe.
Yep, I was in Oregon.
Any observations that were stark revelations among those different people groups and how medicine got delivered or received?
Yeah. I mean, I would say the more urban, the more uptight people are, to be honest with you. I mean,
makes sense.
I think they live in a fast-paced world, and that translates into the medicine. So, like, people in Oregon are pretty chill. It's funny, being from Boston, everything, when you meet someone in Boston, they say, "Oh, where did you go to grad school?" is like the first question. And then when you're in Oregon, they say, "Hey, what color is your kayak?" They don't care where you went to school. It's all about the equipment.
Isn't that awesome?
It was a lovely place. What have I observed? I would say medicine. I was in Vegas for a while. That was very interesting too. I would say there's certain cities that work on favors. You rub my back, you scratch my back, I'll scratch yours. That's kind of, Chicago was very much like that, and in Las Vegas was kind of like that. But I mean, the good news is the people are always good people everywhere. It's how often they look at their watch is maybe based on the time zone, city, east, west kind of thing. So
yeah, interesting.
Yeah.
You mentioned now you have time to think and learn new things. If I think about the opposite of that, is no time to think and learn new things, which would be where you came from. That's concerning.
And magnify that by the fact that the stuff that they taught me isn't really true. Just think, right? Like, recently our food pyramid flipped upside down. But 20 years ago,
isn't that funny?
I had the other food pyramid, and I would have said to you, "Hey, if you want to lose weight, it doesn't matter what you eat. It's just the calories in versus the calories out, right? We're just thermodynamic reactions. So you're going to gain weight or lose weight. It just depends on the calories. Doesn't matter if it's a Twinkie, doesn't matter if it's a salad. There's just this formula, and that determines your weight." And like, that is the most ridiculously wrong thing ever. But I remember those words coming out of my mouth, and I mean, that was exactly what I was taught. And you believe your teachers and the journals and stuff, and it's just amazing to me how that's crazy talk.
When did you start thinking differently?
Love it or hate it, this GLP-1 craze sort of got me thinking about metabolism and, insulin resistance and stuff. And, again, back in the old days, cholesterol was the only thing that mattered. What's your cholesterol? What's your good? What's your bad? And it's just interesting with weight loss, metabolic health, these sort of changes in medicine. Yeah, and the patients are so much more educated, because it was easy to be relatively superficially engaged with the knowledge, because no one was going to push you. And now, oh my gosh, someone comes in and, Huberman, had this, and, Atia told, these podcasters who are doing like longevity medicine, and, like, you better be on your toes. So, it's so much nicer to care for people who can go deeper and deeper into the conversation, but it also pushes the doctor like, hey, I need to dive in a little bit more. So, once upon a time, it was just, what's your cholesterol? We'll just knock those numbers down with a medication, and, good to go. And just the more you learn about it, it's just more complicated than that.
Is there like a deprogramming process for you personally coming out of the traditional system into?
Absolutely. So in the traditional system, like, everything's been sort of predetermined. I almost feel like it's a little robotic, and that, there's always a patient waiting. You're always moving forward. You don't question what the system tells you is the right way of measuring things, right? You have the insurance company telling you that, this person's LDL, the bad cholesterol should be under 100. And since they're 101, you must increase their medication to make their number under 100. Like that's actually a thing, right? There's pay for performance measures if your doctor can get your number under this. So, you have these sort of menus of cookbook things, and you're busy enough that you're just trying to do that kind of medicine. And then once you're kind of move into the wild, wild west, where your goal is to just care for this person, all of a sudden, that completely gets turned on its head. And you realize that, trying to knock their cholesterol down 1 point to make their insurance company happy is utterly ridiculous. Everyone knows that's ridiculous, but, like all of a sudden you realize, my job is to care for the individual. And, it changes how you think about things. So I think doing this kind of medicine all of a sudden, and in the beginning, so I would never tell people to do it my way, but I came to Carmel, Indiana, and opened with, 0 patients. I hadn't been in the area. I have 0 reputation, and, you open up and, you wait for the first person to come by. That gives you a lot of time to think. That gives you a lot of time to learn, relearn, educate, take some classes. So you almost had this sort of, this slow start, a different mindset, it gave you this, I wouldn't trade it for the world, but financially, it takes a while to get going and things like that. So
are you following some of these? I don't know if they're AI as much as they are just sort of documentation, and maybe there's an AI piece to it, where you've got all these different doctors spread across the country, even the world, collecting information on sometimes specialty cases. And they're able to have breakthroughs because you have your intelligent brain plus 15, 20, 30 others focusing on a certain issue with multiple different patients. And sometimes those studies before would take for years. Are you following some of those? And I guess, do you get excited about that? Do you get scared about that as a greater mechanism in this medical care and delivery? I go back to, so the old local doctor, Doc Baker, if you think about Little House on the Prairie. So my grandfather, born 1901, goes to IU Med School, graduates 1926, practices for 50 years in the south side of Indianapolis. And I'd like to think that he did well by his patients. He actually did get paid in vegetables. That was a strong family story, did home deliveries. But the reality is he knew what he knew, and he knew what he could read and be taught. But today we have a lot more tools. Are you using those tools? Do they excite you or do they scare you?
So I'd say it's a little bit of both, because one, it is exciting to think that there's, breakthroughs coming, and again, pooling data to get the real answer. Of course, that's got to push medicine forward. So I think it's great. The problem is I become much more distrustful on where the data is coming from and who's collecting it. And I mean, let's not go too far, but like just COVID, what happened during COVID? Like I worked in a COVID clinic during COVID. Like I literally wore a hazmat suit, and every night I would go home and sleep in a camper in my driveway because I was, I wasn't going to go home to my wife because I'd probably kill her with a germ or something, But I can tell you now, years later, having like been right there at frontline, like I don't really know what happened in terms of like what's the truth, I don't know, and I think there's competitive data sets out there that, the vaccine works, the vaccine doesn't, ivermectin works, it's become very politicized, but I don't know if the data is any good.
Isn't that terrible?
So
in an industry and a service based on data, like we have to, does this pill work? Does this treatment work? Does this therapy make sense? Should you jump on your left foot 10 times to cure that disease? Yes, it'll work. No, jump 11 times. But if everybody's questioning the data, oh man, where does that lead us?
Yeah. So I get this journal every month, and it has, pertinent topics, and they tell you the evidence-based practices, and it's just very interesting because then you try and relate that to your patient, and sometimes it just, there's extraordinary circumstances or something. It doesn't always fit. But there's some people who are very dogmatic that they say, well, the latest study says, and you hear certain, and there's certain types of doctors that are more data driven. Some of our specialist colleagues, internal medicine, whereas I think the family doctors always had a little bit of leeway. There's a little bit of how we feel about it. There's, but yeah, so I have to say I'm a little nervous about who's producing the data, who, follow the money. Yeah, so I think it's a great thing if our sources, if it's good sources, but again, I'm a little nervous about where the data is coming from because right, like the drug companies are the ones that are doing the data on their drugs. Right. So, like, I don't know. It's kind of like asking a student to grade their paper. Like I'm sure they do great work and maybe they do most of the time, but I don't know. Knowing human nature. Yeah. So I'm a little nervous about it, but I do think AI is amazing, and it's a tool like a hammer, right? You can club somebody with it, or you can build a house. So I think,
is there an AI tool totally captive to direct primary care physicians?
They do have several different things, and every month there's something new. So, in the old days, if you wanted to get some medical knowledge, you would go to, the library, and you would look up in PubMed all the articles and read all the articles. Now we have some medical websites that you can now ask a question, and it will cross-reference all the different articles, and then it will help you answer a very specific clinical question, So that's just beautiful. And it's very interactive. And I think that's hugely positive, as opposed to, a study done by a certain drug company. Yeah. So yeah, there's some great tools. And just, the old fashioned, when I started in medicine, I had a pencil and a chart, and I would be writing in the chart while the patient was there. And then hours after the patient left, I'd be writing in this chart in my illegible doctor handwriting. And then it got all fancy. We had a dictaphone, and I would, blah, 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 spit it out. And then somebody would type it for me, and we would literally glue it in as a separate piece of paper in the chart, which is like god awful. But some doctors hand wrote their charts days after the appointment, or they dictated all their charts on Sunday from the whole week. And like, I never did that, but like, that's very common for people to be behind on their charts. And and then we started hiring scribes, medical students or high school kids to, type it in for us. I'm sure you've been to a doctor who all they do is like data entry while they won't look at you, kind of thing. So now, again, with AI, love it or hate it, you can definitely have the visit recorded and a transcript created. Yep. And I think that's an amazing thing, because now doctor, like you literally, so an example would be like, geez, I saw a patient 3 days ago. I can't remember if they told me they're allergic to penicillin or are they taking penicillin? Huh.
That's a big difference.
But of course, now you have this transcript, and you can ask it like, hey, what was going on with so it's so much better. So, but so much of medical documentation has nothing to do with the patient, the care of the patient, the doctor. It's again to justify the bill you're going to send to the insurance company, and beg for the reimbursement.
Or if I could give you from a suit.
Yeah. It's funny because I don't know too many doctors who but maybe so. There's a local hospital around here that I won't name, and one of our patients is in the hospital, and they send me probably 10 faxes a day that are 20 to 25 pages long each. Every time someone touches my patient's chart in the hospital, I get this verbose garbage. They have every test this patient's ever had in that system comes over with every note. It's just a cut and paste. And if you really read the two documents, there might be 2 lines that are different. And I literally can't read it. I don't have time to read it. So, and again, I think what they're doing is they're justifying why that patient's in the hospital, but they're sending those notes to the insurance company to justify the cost. And once the insurance companies just get their little hands in there, everything becomes so much more complicated. And, you know, again, the fluff, there's so much fluff in charting that it's kind of dangerous, I think. So my notes look different because my notes aren't for insurance companies. It's basically to help me remind myself how to care for this patient. Maybe the patient, you know, we send emails and things like that with like really nice discharge summaries and stuff. But, you know, my notes now have, you know, to-do items and action items and, you know, what if, and hey, this is the differential diagnosis of that. So next time I see him, I'd be like, oh yeah, you know, and it's all of a sudden it's good again. It's for the benefit of the patient, help the doctor care for them. So it's so nice to just kick the insurance company, just kick them out.
Yep.
You know, they're just adding complexity.
Yeah.
You mentioned that earlier you were describing DPC and then you said the comment, a lot of doctors are jumping into this. Why?
Yeah. So I think, again, in the old days, my mentors were very satisfied with their jobs. They worked incredibly hard, but they went home and they slept very well because they cared for people. You know, they just did what was right. You know, to hell with the consequences. They did what was right. And now I think the doctors are kind of herded by their administrators. They're overworked. They're not happy. You know, I haven't met a happy doctor in a long time who says, you know, no, I really like these 7-minute visits. You know, I think that's great. I'd like to see more. You know, like the doctors have like that 10,000-mile stare, you know, 1,000-mile stare where they like look like they're on death row or something. So I think a lot of them just maybe the money's even good, but they can't. They can't keep doing this. So I think a lot of people are like, hey, I've heard about this direct primary care thing. I can see 5 patients a day and not starve to death. So I think that drives it. But you know, I couldn't have done this medicine when I was younger because you see so many less patients face to face that, you know, there is something about seeing shingles for 100 times.
No, that's a good point.
You know, it's shingles, but you know, there are some people who do this who, you know, maybe they're fresh out of residency. They haven't really logged those long, you know, those years where you saw 5,000 patients in a year. Or, you know, we have, and again, my wife's a nurse practitioner. We love nurse practitioners, but there's some very young nurse practitioners who maybe are jumping into direct primary care that, you know, maybe they haven't seen 20 cases of, you know, something, you know, so your numbers aren't there. So for me, I'm really more confident in the medicine. You know, I'm a lousy businessman. I'm a terrible marketer, but the medicine is like pretty good. You know, just being a 30-year in.
So there could be some risk for new people, new professionals, new doctors coming into this space and not getting as many reps if they go into DPC. That actually could be a negative the other way of like, it's important to get reps. It's important to have oversight and have some coaching and that kind of thing. So if you're on your own right out of the gate, that could be a problem professionally and for the patients.
Yeah. And the other thing is I'm solo. Not every direct primary care is solo. Some of them have, you know, a couple partners and stuff. But, you know, like in the old days, you just go down the hallway and talk to one of your colleagues and say, hey, can I run this case by you? You know, when, you know, I don't have anyone to do that with. Maybe I have my AI buddy, you know, I can, hey, chat GPT now. But the idea is, you know, you are solo. So you're, you know, so I do think that's interesting. You know, having had your reps is a good thing. But the converse to that is it important to have your doctor, you know, morally injured for 10 years, you know, slaving away before now they're ready for this? So there's a debate in the direct primary care world. Is this good for young graduates, or is this, you know, bad for young graduates? And, you know, I think there's pros and cons for sure.
So it goes back to bringing a young person into a practice that has 2 or 3 people, much like it was back in the 30s and 40s and 50s, where
yeah, mentorship matters. But, you know, I've had some like medical students call and say, hey, I'd love to shadow you. And you know, I'm always like, oh, I'd love to have you. And then I'm like, well, today we saw 3 patients. I answered 45 emails and did 20 texts, and but like to watch that would be probably very painful. Whereas when I worked like in urgent care, I think one shift I saw 66 people, and
Whoa.
that was $6 an hour for 12 hours, I mean, whatever it was. I can't remember what the math was, but it was like, but if I was a medical student, that would have been awesome.
Yeah.
Right. This one's bleeding. That one's got a broken toe. Like, you would have loved to see all that. Whereas if someone comes in and shadows me, I think they might fall asleep because they're like, you don't see that many patients. And the answer is, but we manage them all. Yeah, it's kind of interesting. I think that the statistics go that you see about 1% of your practice per day, and you manage about 3% of your practice per day. So, I mean, if you have 500 patients, you'll see 5 a day, and you'll do 15 interactions, but just 5. I found that number's a little skewed. I think the number of patients you see might be 1%, but the number of patients you manage, or at least in my practice, we're managing more of them more frequently, I guess.
Yeah, I had a question. You mentioned earlier about you were a well-read atheist in the religion school, and you're in biology.
Yeah.
But you also said that you had a 15-minute shower experience that changed your life forever. How did you, you mentioned creation and that kind of thing. How did you settle the score with your faith in science? What was that process like?
Yeah. So I've had several years to reflect, and what I've come down to, and this is not new, but it's your worldview, right? If you think of yourself as a scientist and someone tells you that dinosaur bones are 200 million years old, anything contrary to that is unlikely to compete with your worldview. Your friends share your worldview. Your school, you develop this worldview, and then it's funny because when you're a Christian, you have this completely other worldview, and you're like, all that other stuff, like that's craziness. Like when I look at the human ear or the human eye, once upon a time I would have said, oh, how many millions of years would it have taken, for this ear to look just like a trumpet and have all these neat little curves that magnify sound and pull it into one little spot. And then you have these hair cells that keep out dirt and bugs. And then you have this little membrane that just fiddles at the right frequency to give you that hearing. Boy, that must have taken millions of years. Or you look at that and say, oh my, yeah, that's a great design. Like, of course that didn't evolve, like how many ears would have been on upside down? And what if you had 3 ears rather than 2 ears? Like the evolutionary model, I think really doesn't make sense, because every positive mutation might have 20 negative mutations, and it doesn't add up. It doesn't make any sense. So when you look at it from, we're in the image of God, and God had some great designs, and, he really liked, 5 fingery things. So he put those in whales, and he put those in certain fish, and he put those in salamanders, and he put those in humans. Like, it was a great design. So he carried it forward. But yeah, to me, it was all evolution. But it's impossible, right? How do you create, like, the bombardier beetle? I always go back to that sucker. Do you know about the bombardier beetle?
Mm-mm.
So
No.
there's a beetle, the bombardier beetle, and it has 2 anal glands. One of them has a certain chemical. The other gland has a different chemical. And they just sit inert in the animal. And then when they shoot both of those chemicals together, it literally boils at, 212 degrees Fahrenheit and creates a little explosion. So if you're going to eat a bombardier beetle, they'll shoot you in the face with boiling hot, So tell me how that evolved, because maybe let's do a couple million years with an anal gland on the right, but it doesn't do anything unless you have the other one. Like, you need 2 pieces to make that work to be an evolutionary advantage that would, set you aside, kind of thing. So yeah, same sort of thing. Like,
Well, reproduction
Yeah,
I mean, take the same thing to reproduction.
Right.
If that's not right out of the get-go, that doesn't exist.
Right. You need both. And I mean, and there's definitely people who could try and explain it, but to me, like it's infinitesimal. Like if you go to the flagella, in these one cell organisms, they have this little hair that flitters around, and that's how they move around in that primordial space, that soup. The engineering of the flagella is beyond what we can do. So you just can't tell me you put it in a soup and mixed it and shot it with some lightning, and you got that. Like there's zero. It isn't going to happen. But anyway, so I think I went from a worldview of it's always science. We can always explain it. I can go back to all of the scientists. Ironically, all of those scientists, the Isaac Newtons, they were all Christians. It's amazing. They did their science because they wanted to see how God did it. That was what pushed all that science. And now, of course, we use science as sort of a hammer to knock down, religion and stuff like that. But so I think my worldview, just once you know what the truth is, and then you reevaluate it with this different worldview, all of a sudden you see silliness in what you thought was fact. It just all of a sudden you look at it and that doesn't add up at all. It makes no sense to me, again. So, but I had my little, conversion. Some days I feel like my name was Saul turned into Paul. So
it's interesting what you just said about worldview and science and creation and your faith is similar to your journey with medicine of being told something and believing it and looking into it later and being like, wait a second.
Yeah, that's a good observation.
It's really interesting. And on this idea of worldview, I think it's important to share how we met and why from my perspective, I think DPC is extremely valuable for society, for American society, and why having a relationship with a doctor is extremely important. But from my experience, I looked into the DPC world because if something, if everything's hitting the proverbial fan, I want an advocate in my corner that will show up. And what I didn't see in a traditional physician setting is the possibility of that. So I was researching in DPC, and we also have this tool called Garner, which ranks doctors. So I went through probably 40 DPC practices in Indianapolis and compared it against Garner to get the top providers. And there's some flaw in that, really, because once you get into DPC, you're going to fall out of all of those tools because you're not billing an insurance. But you were one of those folks. And I reached out to you as a high quality doctor that's practicing DPC. And I said, hey, can we grab coffee? Because I wanted to talk to you. I wanted to learn about your worldview of medicine and how you treat patients. And you responded and said, sure. And so we went and grabbed coffee. I don't know if you remember that, but
yeah, I do.
We had a conversation and, I asked you, hey, what happened during COVID? And we had a conversation about that. And, we really got to dive into kind of worldview and belief on medicine. And through that experience, I was like, hey, he's my guy. Like, he knows what he's doing. He's an investigator. Obviously, you've explained through this whole podcast how you're an investigator and you explore and research. I saw that in our first interview, but then we started. You became my doctor, and what I think is just so cool is like we can text. I'll send you podcasts. Like we engage in like learning about lots of things, or even if it's just me sharing worldview, like we're getting to know each other. And I just think that's really neat. And I think it's just really sad that most of America does not have a relationship with their doctor like that. And if what hits the proverbial fan, like they're by themselves. And I just think that is so sad. I guess that's my encouragement to anyone listening to this to really look into their primary care relationship. Obviously, I have a recommendation, and he's on this show, but I just think that that's really important. I mean, to the fact that like I invited you to our healthcare conference and you registered and you're coming. Like, who has their doctor that's coming to their healthcare conference? Who has a doctor that's meeting them for coffee, or will at least like entertained receiving like shared podcast episodes about whatever healthcare topic. I mean, that's so unique. I'm very appreciative of that, but I think that's just important to share that there is something different out there. And the reality is a DPC membership isn't like a budget buster. There is an investment, but to your point, once you have a couple of visits and once you have this and that, it'll pay for itself. You're already paying for it anyway through the probably lousy health insurance someone has. I can't recommend DPC more highly.
Well, I appreciate it. Thank you for the kind words. Yeah.
So man, an hour and it went so quick. We're coming to the end of our episode, and we typically ask our guests 2 questions that we would like to ask you, Dr. Burrer. And the first question is this: what is a risk that you have taken that has changed your life?
I mean, I guess it'd be obvious, right? I after a relatively, enjoyable career in standard medicine, I kind of threw it all away. Not threw it away. That sounds too, but I basically tried to do something that was incredibly different, probably financially not really wise. It would have maybe been a wiser plan to just ride out another 10 or 15 years in the system rather than, open a practice, and do something completely different, start with very few patients and get going. And I would say the other thing about our practice is we live here, which I think sort of sets us apart. So my wife and I, at this stage of our career, we kind of went all in, and that was probably risky, but the reward is absolutely there.
Well, and you are literally to build that out a little bit. You are in Carmel basically on Main Street in a converted commercial house where you practice medicine on the first level and live upstairs, right?
Yep.
Small town medicine, like you dreamed it up before when you were sick.
It is exactly my childhood dream. So yeah, how many people get to sit there and say, yeah, no, I'm living the dream. I can literally say I am. So yeah, that was probably our biggest, my wife and I's kind of biggest risk.
Very cool. Second question, Dr. Burrer, what is left yet unfinished that you guys have the resolve to complete?
So I will say that I guess I have a couple maybe sort of answers to that. So one, for some reason, I've always been very, 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 very curious. So I would say there is no resolution to, there is no completing that. Like as soon as you learn something, it's like, what's the next thing? What's the next thing? What's the next thing? An example being Ben invited me to the Shroud, keynote speaker, and I am a Shroudie. I have spent, I cannot tell you how many hours reading about that. Like that is absolutely fascinating to me. So, I think the quest for knowledge is the next thing, and you never really sort of get there. And then I think I also throw it back into sort of religious life. Like every time you read that Bible, there's something else in there. And I cannot tell you how many times I get goosebumps reading something I've read many times or have someone explain it to me. So I think, the quest for knowledge to get, professionally, but in spiritual life, like there's always so much more out there. So, I don't think we'll ever resolve anything that way. We'll just keep pressing because the journey is awesome.
Good answer. Thank you.
Well, Dr. Burr, thanks for joining us today. And thanks to our listeners for joining us on another episode of Risk and Resolve. We'll catch you next time.
Thanks for tuning in to Risk and Resolve. See you next time.